Good morning. Thank you very much for the nice introduction. I'm going to talk about strategies for explanting intraocular lenses and putting new lenses in. And I will divide my talk into sections. The first sections will be about patients that have already undergone phakic intraocular lens implantation, and then after a couple of years, these lenses need to be removed because they get a cataract or have some other issues in terms of cornea. And this is important, especially as those who got a phakic lens 10 or 15 years ago, there was not much choice. So they got like a PMMA, anterior chamber lenses and so on, which is not so easy to remove. These are my disclosures. So this is a typical situation we face more and more nowadays. Patients having an anterior chamber phakic IOL, those are usually high myopic patients, minus 15, 20 diopters. And then you have to decide, how do I get a big lens like this, 6 millimeter out of the eye? Where do I do the incisions? And how do I handle that? Do I go through the sclera, the cornea? And it depends. If they have some astigmatism, you may actually go, and as in this case I did, through the cornea and suture the incision in order to reduce astigmatism by this. But then you have to do a second incision to do your phaco. So let's go through this case. As you see here, this lens is a anterior chamber lens, phakic IOL, 6 millimeter, 5.5 millimeter optic. And we will do an incision here after we put in the viscoelastic at this plane here in order to get the lens out of the anterior chamber. For this I use a 2.5 millimeter knife, and I extend this in a kind of frown incision in the limbal area to have like a 6 millimeter incision here. Then we have to mobilize the lens and get it out of the incision like this. And you have to be careful. Sometimes it is kind of adhered to the structures of the trabecular meshwork or to the iris. And then you can just take it with a normal forceps and get the whole lens dialed out, as you can see here. Then we will put a 10-0 nylon suture here, bury the node, and go like here in order to do the phaco, which is then no big deal, as a matter of fact, depending how much cataract you have. This is a myopic patient who have a deep anterior chamber, and it's a more cortical cataract here and can be removed quite easily. Then I implant the lens without viscoelastic, just under irrigation. It's a hydrophilic lens from Zeiss, so we have the chamber open with irrigation, and then the lens is inserted directly into the capsular bag, as you can see here. And now the case is done. You don't need to remove viscoelastic because it was implanted under irrigation. This works quite well. Can you use a femtolaser in case of an anterior chamber lens or in case of a phakic intraocular lens? And do you have any advantage? Yes, you may do that, especially if you want to have a very good capsulotomy. Sometimes your maneuver in the anterior chamber can kind of injure the anterior surface of the capsule. So doing this would be quite interesting. However, you have to cheat because the software of the femtolaser doesn't differentiate between the phakic IOL and the anterior surface of the lens. Yeah, luckily you can actually tell the program where is the lens and where is the cataract, and in this way you can do that. Here we have a case of a lens which is called the Cachet lens. It was a, oops, what is that? Can you start again? And now? Can you take over and open it again? Okay. Let's just go over here. Oh, wait a second. Here we go. Okay, I'm not touching it. So you see here we have the rexis already behind the lens, and this is a so-called cachet lens. It's also a phakic IOL, which was quite popular. It's a hydrophobic acrylic, so we have to cut it. We don't need to cut it 100%, just that it can be kind of folded out like this, and then we can take it out through a 3mm incision, and then actually we can do the phaco as a normal phaco and put a lens in. I don't want to spend too much time on this. The only interesting thing here, this is a so-called zero phaco handpiece. There's no phaco, it's just an aspiration handpiece with a bigger opening, and in combination with the femtosecond laser, you can actually aspirate in a very nice fashion, almost like a phaco, the whole lens, without using any kind of ultrasound. So this is purely zero phaco cataract surgery here. Let's go further. It becomes tricky if you have like a lens which is fixated in the iris. Like this is an Artiflex lens. We already did a femtosecond laser capsulotomy and fragmentation, and now we have to de-enclavate this lens. And you need the specific instruments for this, like you see here. But it's quite easy actually to do. You hold the haptics, and with a spatula you go through paracentesis and de-enclavate the lens. But you need to have this specific forceps because you have to hold the haptics in order to have a firm grip, but it can be done quite easy. And as the lens is pretty soft, you don't really need to enlarge much. This incision here is like 3mm, and we just go in with a strong forceps, grab the lens, and with a little bit of counter pressure here, I take the spatula and we can take it out. And then we can just proceed with the cataract surgery. There's nothing special about that. Okay, let's go on. So let's move now to the posterior segment. Sometimes you have the situation where not only the lens is decentered, but the whole capsular bag with some Sommering's ring, and sometimes, especially if you have pseudoexfoliation syndrome, there's even a capsular tension ring in it, and it's kind of just hanging on the vitreous. And then you have to think about, do I do an anterior approach, a posterior approach, or both? And how do I implant the other lens in this eye? So what I usually do is I take a trocar to have an approach from behind. And even if I just use it at the beginning to have a counter pressure and make sure that the whole segment is not dropping down, it will help me to move the whole segment into the anterior chamber. Once I have the whole thing, including capsular bag and Sommering's ring in the anterior chamber, it's much easier to take it out without any problems. Here, I actually did a clear cornea incision of like 5mm in order to get this out, because this is a PMMA intraocular lens. And try to take it out here, but I then take a forceps because it's a little bit too big to just slide it out with the spatula, but here with a Doden forceps you can take out everything. And then because I will put a retropupillary fixated iris fixated lens in the eye, I do a thorough vitrectomy. You don't need a second trocar. You can just go through the paracentesis with the irrigation and do the vitrectomy from behind, from pars plana. In this case, make sure that there's nothing left behind. Then we put the artisan lens first in the anterior chamber, and we assign it from 3 to 9, like here. And then we will fixate it behind the iris, not onto the iris, behind the iris, which has become a routine. It's much, much faster than transcleral fixation. This is unedited. It takes just a minute to put the lens in. So you put it under the iris, you lift it up, and then you can easily see how to enclavate it from this part. And you do the same on the other side. As you can see here, take it in, take it down, lift it up, and just put it in with a small spatula, very easy. and then the whole thing is more or less done. In Germany, we have experience for more than 15 years with the retropupillary fixation. It really is a very elegant method. Here I close the wound and then take off the trocar, and the whole thing is actually done in a fairly small amount of time. And with this, surgery is more or less finished. Sometimes you have the situation where you cannot really see what's going on. Like here we have a trifocal intraocular lens, which is obviously decentered, and part of the lens is inside the capsular bag, part is outside, and the patient suffers from a lot of problems because of the decentration of the lens and the fibrosis of the capsule. And sometimes you have to decide, do I have to take the lens out, or can I kind of repair it? And you sometimes only see that during surgery. So in this case, it was quite difficult actually to see, is the lens in the bag or out of the bag, and what is fibrosing with what. First you, of course, put some viscoelastic in it, and I like to use a cohesive viscoelastic like Helon or Helon GV to do that. And you can see here that apparently this haptic here is out and the rest of the lens is somewhat in. So it's a very strange situation. First of all, I try to kind of loosen the adherences here to make sure that I can move the lens. And there's kind of second layer also. Some lens epithelial cells have grown over the lens again. So you have to be very careful because you want to preserve the capsular bag for another implant, or if possible even for repositioning of the lens. But there's some adhesion there, but slowly you can loosen it. And on the other side it's similar. Slowly, careful, we get through it. So this looks much better now. Now we get an idea what's going on here. So we see that the lens can be moved and that we can separate anterior and posterior lens capsule. There's still some adhesion here, which we carefully and with a blunt spatula try to get off. And then we use a lot of viscoelastic behind the lens to expand the posterior part of the capsule. And now you can see that we can push the lens back in the capsular bag, like here. Now we are back in business. Now we can centrate the lens. And in order to make sure it will not decenter, we just put it 90 degrees away from its initial situation. And now it looks much better. We didn't need to explant the lens, and we could handle the situation. The patient was very happy. I then also used the vitrectomy to cut out some of the fibrosis here, make a larger opening, and then everything was fine. But sometimes there's also the problem that you have to remove, and not only because the lens is not in the capsular bag, especially in high myopic patients, these plate haptics are sometimes too small for the capsular bag. Here this patient got a trifocal toric intraocular lens, and it was completely decentered, as you can see here already on the picture. And if you look here in the video, the moment I go in with the irrigation, you can see that the lens is jumping back and forth in the capsular bag. You see here, you see, it's really, the capsular bag is way too big for this lens. And this is not a really high myopic patient, was like -6 or -8, but with a like almost 30 millimeter length of the axial length. So in this case, you have to remove the lens. And what is always okay in this case is to put a classical C-loop 13 millimeter overall diameter lens in the capsular bag. And this is what we did here. We first remove the lens, and the lens, this hydrophilic lens is very soft. You can actually grab it through the incision and take it out. It doesn't really look that small if you look at it, this here, but it was obviously too small. And then a classical Technis bifocal, multifocal toric lens was implanted in this patient, and at the end it was very happy about it with this lens, so it was okay. But as I said here, the reason for explantation was here a too small, undersized intraocular lens. And now we just put the lens in place with the toricity in the right direction. So these are just a few case samples of everyday situation, patient coming in, and the more ophthalmology advance, a lot of these phakic IOLs that have been implanted 15 years ago or 20 years ago now come to us. Now these patients are 60, 70, 80, and they have a cataract, they have some compromised endothelium, so we have to have strategies how to get along with that. And also these cases that we put lenses in quite a while ago, and now the zonules have dissolved and the Sommerings ring has built up. These are the challenges that come nowadays in our offices, in our practices, and there are intelligent ways to handle that. And yeah, that's just the thing I want to share with you. Thank you very much.